So may I ask a question about the tumor rupture that you show us? So what is a risk factor that can easily happen, the tumor rupture complication? So do you have any comment for this? And
I think it's because tumor rupture, nodule rupture is not very common. It's really rare. Because for me, I think I only have four patients. I only have 4 cases of tumor rupture. So actually, I don't know the risk factor for tumor rupture. In some situation, the patient for some patient during the whole procedure, they complain, they pain, they feel swelling, they feel all kinds of discomfort during the whole procedure. But after that, they did not have nodule rupture. But for my 4 patients, in my memory, they did not complain any discomfort during the whole procedure. But after 1 month, I just encountered the nodule rupture. So it's very difficult for us to predict in what situation the patient will have this kind of complication. But the most important thing is once we really encounter nodule rupture, how do we manage this situation? And in some situation, if the nodule was too big, sometimes maybe we need some surgical intervention. Even we have to recommend the patient receive surgical resection. But fortunately for me, for my all 4 patients, they just receive conservative treatment. I give them some medication, antibiotics, and keep drainage. Sometimes you can see the small wound, so the pus can drain out by themselves. So we just educate our patient to just change the wound, keep clean, don't make the wound infection. It's okay for them. So it's really not common. But if you do if the case number was quite big, one day we really encounter this situation. But I think we don't have to worry. Just keep observation, prescribe some medicine for them first, and after that, just request our patient to take care of their wound. Yeah.
So do we need to do the aspiration in case of this? So yeah, I saw you show like a pus coming out.
Yeah,
so
it's very interesting. Usually the patient for the first, I think for the whole process, initially the patient will complain swelling, but at that time the skin still intact. But after that, our stress muscle, initially the stress muscle will go outside because of the accumulated fluid. So initially the neck will become swelling, much more swelling than before. After that, because the stress muscle will come back to the normal size, so the fluid will go through the stress muscle. And after that, you can see something, you can see pus-like wound, and they just keep drainage out. Maybe my patient told me maybe they have to change their wound for maybe 1 week. So we don't have to aspirate because sometimes it's very sticky, very, very sticky. It's very difficult for us to aspirate all of the internal fluid. Just keep them freely drained out of the wound. But the most important thing, we have to educate our patient, not cause infection to the internal fluid, because if once it's get infected, it's really very big problem. Yeah.
Okay, thank you. So let me ask Dr. Chu, you mentioned about the investigation before performing ablation in the malignancy case. So, but for the lymph node, it's very difficult to tell this is a malignant or the normal lymph node. So you think the follow-up is enough, or you think the preoperative investigation should be added, the CT or MRI or the PET scan?
So I think for PTC, the RAI is helpful. The radio iodine scan is helpful. As the patient gets, so what you'll find is that you do RAI every once a year, and then after it's helpful, but in between I just do ultrasound. It is just too much radiation, actually.
Okay.
So I have a question, if you don't mind so much. Okay.
Sure.
So I mean, I don't do microwave, but technically, what is the difference between RFA and microwave when you're actually doing it? Now we know that when we do RFA, right, we hear the pop, and sometimes when the resistance goes up, it cuts off. And to me, that's a safety feature, which microwave doesn't have. And especially when I'm doing parathyroid adenomas with the 3 mm needle, I like that safety feature so I don't burn the nerve. So for those who have experience with microwave, maybe we can hear some. So when I transit from RFA to microwave, what should I be looking out for?
Microwave ablation is now mainly used in China, and because it can covered easily by medical insurance. So many patients would like to receive microwave ablation currently in my province. Briefly, microwave can produce a faster and a larger ablation, and sometimes it may cause easily damage to some important structures surrounding thyroid capsule. So the hydrodissection, enough hydrodissection is really essential before you start the ablation. And in my personal experience, and 2 patients with hyperparathyroidism and microthyroid, papillary thyroid microcarcinoma occurred a mild damage to laryngeal nerve, a recurrent laryngeal nerve, and one recovered 4 months after ablation, and another one is still during the recovery, and the patient still complains of voice change of hoarseness. So I think for our clinicians, radiofrequency may be show a slightly higher efficacy and safety in the treatment of even it is not statistically different in our randomized control study. This is a minimum randomized control study, and we randomized these patients was randomized into 2 groups. Even the samples is still very, very small. And another difference is the needle of radiofrequency ablation is much, how to say, sharp.
Yes.
Yes.
It can easily be injected into the thyroid nodule. So I think the main is between these 2 techniques.
Thank you very much.
Okay, thank you. So I think one of the questions is about the hard nodule. So I'm not sure, is that mean the calcified nodule, maybe the big calcified nodule, can we do ablation or not? Have you done for that?
Calcified nodule? Because for the calcified nodule, sometimes if we perform fine needle aspiration for the calcified nodule, it's, I don't know, but for me, it's almost impossible to use the needle penetrate the calcified nodule. Even I use really very strong, I cannot penetrate the calcified nodule. So I don't have any experience to treat calcified nodule by using IFA or other method. I think it's still kinds of limitation. Maybe it's kind of limitation for the thermal operation.
And it can be dissolved by thyroid. I mean the calcified area cannot be ablated and be dissolved by thyroid tissue.
Mm-hmm. Yes, agree. What about the microwave? You think can they lyse the calcium?
I don't think so. Microwave is more like a micro oven, you know. It can heat faster and quickly.
But the mechanism should be the same, right?
Yeah.